Hello, I'm Dr. Tom Lazier, and welcome to our on-call after hours. Well, we're answering some of the questions that we weren't able to get to during our broadcast portion of our show. All of your questions are important to us, and we want to answer as many as we can for you. So we're going to begin right here. We had several questions on rosacea, and I get to see a lot of that in my office also because of the rash portion of the rosacea. And I actually have patients coming in with other problems, and I ask them if they get flushy and that kind of thing.
Well, you know, rosacea is a very common disease, about 15% of the population, and I like to tell people this is multifactorial. There's more than one thing going on here, and you know, perhaps we don't understand completely what's going on, but we know there are certain things, and that is that, number one, rosacea gets worse in the summertime, and the reason that happens is there's a chemical in the skin called cathelicidin, and cathelicidin is there to protect us against infection.
I'm glad you can pronounce that.
I spent weeks learning this, but cathelicidin protects us against staph infection and other bacterial infection, but we only need so much. But sunlight triggers cathelicidin production, and when you increase the cathelicidin, you inflame the blood vessels, you inflame the oil glands, and that's what's happening. So when you look at rosacea, there are basically a couple elements. There's redness because the skin is inflamed. There's inflammation of the oil glands because the pustules are active, and there can be a flushing along with it. And so when we talk about rosacea, we talk about red skin, we talk about pimples on the nose, and we talk about inflammation around the eyes, or blepharitis, because the oil glands of the eyes are involved too. So when we talk about how you're going to treat this, we start out and say, well, what's the primary element? Sometimes it's inflammatory papules, and this is where antibiotics can be helpful. You control it, you don't cure it, you may have to treat it for as long as 5 years, but that can help. If you don't treat it, about 1% of the population can go on to rhinophyma, which is the W.C. Fields nose. And unfortunately, once you get that, about the only thing you can do is come to me and then I blast your nose off with a laser. Not a good plan. The erythema is sometimes helped with antibiotics, but a lot of times what we find is that what we need to do is take away the redness. And so we look at it with a magnifying glass. If you can see blood vessels, lasers are helpful. If it's just flushing, there's a new medicine called Mirvaso that helps with that. So we do have some tools for it. The big issue, I think, in the majority of the people is that inflammation around the eyes, the blepharitis, because if you have blepharitis, your eyes are sore, it's like there's sand in there. That's where antibiotics are pretty helpful. Or you can go with the cyclosporin drops. And we've got a famous lady eye doctor here in Sioux Falls that is on TV telling us about Restasis, which is topical cyclosporin. And that can be helpful, but again, pretty spendy. So rosacea, basically probably triggered by sunlight, exacerbated by things you do on the skin. And so if you're using harsh soaps, strong irritating products, you're going to exacerbate it. So we always start out with basics: gentle cleansers, no soap. Use light moisturizers, no fragrance. That's going to help you. And then you kind of look at it and say, well, how much do we need to do? Some people need a lot of medicine to control it. Some people get away with a little. There are some topical antibiotics that are helpful for some, but a lot of times they just keep you busy.
Now, I've noticed that there are a lot of times on oral antibiotic, particularly the tetracycline group.
Exactly, yep.
And it's worse in the summertime, and that tetracycline is notorious for giving some reactivity. So how do you weigh those two against each other?
Well, you know, that's part of what you may have to look at, is because tetracycline and doxycycline are photosensitizers. And so if the dosage is high enough, you may exacerbate the problem. In other words, make it worse rather than making it better. So it's important to kind of select that out. And the drug that we use often is minocycline, which is one of the tetracycline derivatives that doesn't photosensitize. And you can use that at very minuscule doses, so actually below the antibiotic level. So a level of 40 milligrams of minocycline will control it in many people. And that's important because there's a real segment of adult women that get yeast infection with chronic antibiotics.
Very good.
So if we can get that level down, it's a little better.
I have had patients come in who have reddening of the white part of their eyes and have this thing called ocular rosacea. What's that all about?
Well, what happens is we've got these meibomian glands in the eyes. These are oil glands that lubricate the eyes. So you not only have water or moisture in your eyes, you have oil that lubricates. And one of the things that happens in rosacea is that there's inflammation in those oil glands, and then you get this little crusty stuff. So it's like you got sandpaper in the eyes. And when the conjunctiva gets irritated, that's what we're going to get.
Right, and of course I end up seeing them because they think they have allergic conjunctivitis.
Exactly,
and
yes.
They've got this kind of dry, irritated eye. And I've seen that when they do put on the minocycline, that seems to really help that particular form of the rosacea.
Well, and the interesting thing is minocycline is an anti-inflammatory drug, and we always think of it as an antibiotic, but it has a profound anti-inflammatory effect, and so we use minocycline for a number of inflammatory or autoimmune diseases as well as an antibiotic.
Like rheumatoid arthritis
exactly,
for a while when we were using it for that. We were asked about chronic dermatitis and putting a topical, and they have 1% topical cream on that. And the question is how long is that safe, and how do we judge that we're not going to thin the skin and that kind of thing? And
well, one of the issues is this: steroids are anti-inflammatory, and they're supposed to take away the inflammation, but they don't repair the barrier. So one of the critical things that I teach students is when you come to my office, if you want to repair injured skin, there's two elements. One is take away the inflammation. That's what the steroid does. The second is repair the barrier. That means you're going to have to use something that's lubricating. Creams, lotions, gels are not lubricating. They won't heal it. They'll make it better for 10 days, but as soon as you get there, it's going to come back. If you use an emollient or an ointment, you repair the barrier, and in that case, you can stop the steroid, go on to an emollient, things are going to work out. But that's the failure here, is that in many cases, doctors don't understand there's two elements to healing. Take away the inflammation, repair the barrier. Corticosteroids, even a 1% can injure the skin. What I tend to do is I'm one of these people that likes to use something really strong, heal it, get them off the medication, go on to a moisturizer.
Very good. Excellent. Just thank you very much for that. Now this next one is about problems in the corners of the mouth, and we see that fairly frequently. It has that goofy name, Perlec.
Perlec, yeah.
Yep.
You know, this is an interesting thing because it's kind of part of our aging phenomenon. As we get older, our skin starts to sag. The collagen gets damaged.
Speak for yourself. No,
it does happen to me. But as we get older, this skin starts to sag a little bit, and we develop a crease. And we have yeast in our mouth naturally. And so what happens is you start to colonize this area with a little bit of yeast. And so this is one of those things where sometimes an antibiotic will help it, but more often an anti-yeast medicine will help. But again, it's the same kind of an issue. Remember, there's an injury and there needs to be a repair. So the anti-yeast medicine takes away the yeast, but then you need to repair that skin.
Do you do that topically or do that orally?
I usually do it topically. I'll use a mild monostat or ketoconazole type of anti-yeast medicine.
Does it help
for just a couple days? Probably don't even need to do that. Okay. I don't use nystatin for one reason, and that's cost. Okay. It works, it's expensive, but I always turn back around and say, okay, now that you've got this healed, you need to use a little lip balm there, create a little barrier, because when the skin gets injured, it's going to come back.
Do you think those waxy lymph balms work just as good as emollients and ointments?
Well, and here's the issue. Paraffin or wax-type products will stay longer. Ointments, particularly, which are Vaseline-like base, they don't stay very long. So actually, if you want to get protection on the lips, you got to use a paraffin or wax-based product, which is the lip balms.
Now, is there any problem if those lip balms have flavoring in them?
Absolutely,
and all kind of stuff
absolutely.
Like that?
Simple is better. You know, if you can get something fairly simple, you know, when it's got 12 flavors and all the good scents and tastes like, say, raspberry, remember those are potential allergens. And a number of the products that used to have cinnamon were really great for us because that cinnamic aldehyde, which is the cinnamon flavor, causes a lot of allergies. So you'll see that. Lipstick contains eosin, and some people get allergic to the eosin. So the best answer is if you can get just a basic one, that's fine. There's some of these that have beeswax in it that you can buy, and they're actually pretty good.
Excellent. Thank you. Well, this is pimples on the tops of the hands, and what are the common causes of that? And we know there's a lot of them, but Whenever we have pimples on the tops of hands and routine stuff like harsh, they're usually washing their hands a lot, really beating their skin up. But once we get past that, I usually send them to you.
Well, you hit it right on the head, because most of the time intact normal skin is not going to have this. So what do? Well, soaps, detergent, cleaning agents, you've injured the skin and you've set it up for that. Once in a while it's a staph infection, maybe some other things, and so we kind of look at that, but we start with the basics. What are you doing? What's going on? Why are you getting
hands
this?
take quite a beating under those. We have a couple questions about adult acne or whiteheads on the face in elderly patients. Is that a different process?
That's absolutely a different process, and we call those comedones and cysts of Favre and Roquechot, who are two French dermatologists. And essentially what happens is that as we age, there can be some photo damage that literally leads us to get these little whiteheads and little pustule type things. That's an aging phenomenon. It's not true acne. It's a plugging phenomenon from chronic sunlight.
So people in England who never see the sun don't get as
probably
much of
don't
this
get it. Very common in the French and southern France. What we do with it, topical vitamin A can help, and sometimes an aggressive dermatology nurse will get in there and help you tease out some of those.
Oh, excellent. Thank you. We were asking about psoriasis, and we have a couple questions still, and one of them was about gluten and psoriasis. Have you seen much with that's substantial that says that those two, that TNF-alpha, that the neutrophils are affected by gluten?
We don't see psoriasis affecting the gluten, but what we do see is one of the diseases you see a lot, and that's dermatitis herpetiformis. And that is very much related to the gluten type things, and you can jump in on that.
Well, I think the great thing about it is it used to be a pretty hard diagnosis, except for the itching. The itching was so intense that you just were impressed by their itching. But when they come to your office, they get a biopsy. And then they send it to the dermatologic pathologist. And that guy makes the diagnosis, because he stains that, and it is jump off the screen. That's what it is, no doubt about it, and the wheat, avoiding wheat. And if they come to me and say, well, I still have the rash, I know they're not avoiding wheat.
Absolutely, yeah. Back in the old days when I started, we'd give them Dapsone, we'd give them these sulfa drugs, and you could suppress it. But we didn't really pay a lot of attention to diet, and nowadays we know that if you're not dealing with the diet, if you're not going to a gluten-free diet, you're not going to be successful. And dietitians have done such a spectacular job of putting out gluten-free diets in this day and age that we really limit the amount of medication we're using now. If you're on a gluten-free diet and you've got dermatitis herpetiformis, you can probably go drug-free if you just stay with that gluten-free diet.
Very good. Thank you very much. They ask if diet ever has anything to do with seborrhea. So first thing, tell people what seborrhea is compared to psoriasis and eczema and these other common skin things.
Seborrhea is when you get that little waxy red rash that's kind of along through here, sometimes goes up here. It'll occasionally get down into this area, and really severe, it'll go right into the ears, into the hairline, and some of us guys, it'll be on the chest and even on the back. It's one of those things where we know a little bit about it, we don't know a lot about it, and the reason is because it's such a simple process that when you put a little topical steroid on, it goes away. And because it goes away, we're not going to do any research. So what we can tell you is that there are some little microorganisms in the skin that seem to, when they increase, the seborrheic dermatitis gets worse. So if you use like a ketoconazole shampoo, you can reduce that, and that helps it sometimes. And I actually have some people use the old Nizoral shampoo as a facial wash, because that'll help. But more often than not, a simple 1% hydrocortisone once in a while controls it very well.
Very good. Thank you very much. Well, this is a tough question, and we may just be able to say, we don't know the answer, but does the melanoma affect the nervous system in a way that you might know that you've got it?
Melanoma typically goes through the lymphatics, and so routinely I'd say no, it doesn't normally affect the nerve system.
Right. I think you have to do that skin inspection, because you're not going to know. So you just have to have somebody go over your skin. And,
Exactly.
we don't look under our arms very often, and we definitely don't look at the back end of us very often at all. And you just need to bite the pride and have somebody
get
take
somebody
a look.
looking at it. Yep.
Exactly. Well, this is a very good question that she's talking about post-herpetic neuralgia. And that's this is why we get the shingle shot.
Absolutely.
This is the damage you talked about in the nerves, and I think it's hard to deal with. We have pain management people that have to help these people out. These are our physician colleagues. They have to leave our office and go over there because they have to get injections, these nerve slowing agents like Neurontin, things like that.
Exactly. You know, shingles is a process that migrates the virus migrates down the nerves, and when that happens, the body's immune system seems to destroy the sheath surrounding the nerves, and that produces this chronic pain. And when we go in and kill the virus, we're not necessarily preventing that damage. So when that damage occurs, the virus is gone, everything is healing, well, we're still in pain. We've still got this because we've injured those nerves, and it goes on forever. There have been some studies early on that suggested steroids could help prevent this, and I'm a little bit up and down on that. If a patient comes in and they have a lot of discomfort when they have shingles, I'll give them a burst of steroids, and I hope that it's going to help, but I don't really know. When they get to where they come in and it's gone and they've still got the pain, we're going to start them on medicines that depress the sensation, like doxepin. We'll use the Neurontin you talk about, do the shots. If I can, I like to get them into a pain specialist, and that's the best answer when you can. Sometimes they say, well, you're going to do it, and then I try and help them, but realistically, I'm not the expert, and referral is probably the best answer there.
I have very mixed reviews also on the use of Valtrex, which is an antiviral, or acyclovir, which is the original drug. And I think if they come in early, I think it has some benefit because I think the virus is available.
Yep.
And I think after a week of having the shingles, you've probably exhausted the viral part.
Pretty iffy about what benefits are going to be. The issue with shingles is you got to hit them hard, you got to hit them early, and if you're out there a week or two, the cow's out. The barn is out. You're probably not going to prevent it.
Okay. So our last question is one, and you had touched on this. And I would like you to talk a little bit about the, since I'm an immune guy, I like to hear about the immunity associated with the alopecia that we talked about earlier.
Well, what I tell people is we always start out with alopecia and we kind of go through a pattern. And so the first thing I look at is, where is it? Is it annular plaques? Is it widespread? Is it diffuse? You know, a good number of people have hair loss because it's genetic. Some people will have hair loss because of diseases like lupus and dermatitis retiformis, lichen planus.
So inflammatory kinds of skin, any kind of inflammation.
So I want to rule that out first. Then if somebody comes in, they have like patchy type hair loss, we don't leap right into alopecia areata, which is where we're going with this, but there are people that can have other things. And so one of the things I'll look at is I'll examine it with a magnification and I'll touch it, because there are cases where they can have tumors in the scalp. And the classic one is breast cancer metastasizing to the scalp, which looks just like alopecia areata. But if you touch it and you look at it, with alopecia areata, there are going to be a few little hair follicles, little question mark hairs there. And with the breast cancer, there's nothing. And so that's where one of the steps is, if you're not sure, get a biopsy and get a history, because if they've had something like that, you want to check it. Alopecia areata is one of these really interesting diseases that we don't understand very well. We call it an autoimmune disease because literally the body is attacking the hair follicles. And to the best of our knowledge, what it's doing is not destroying the hair follicle, but inactivating the hair to where it quits growing. So theoretically, even if your hair has been gone for 20 years, it can possibly come back. It traditionally doesn't, but it's possible. And what's going on is there are little lymphocytes surrounding these hair follicles, and they send out little signals that are the immune suppressors that shut this down. And so what do we do if it's mild? Well, we'll give them topical steroids to try and work on it. We'll intralegally inject it. In rare cases, we'll go with oral medicines, but oral medicines are a honeymoon. You can only use them for so long. and then we're done. Now, what you and I were talking about is that there are new medicines coming along that are going to be dramatically effective. And so what we don't know yet is how safe they are, how long-term effective they're going to be, how much do they cost, but we're going to be looking at some good things in the future.
Awesome. So one last question, and this is one that I want you to field with telling us a little bit about sometimes things are so complex that you really have to work through each step because there's 10 or 15 appropriate steps, just like we had just talked about alopecia.
Well, and that's our patient from Astoria, and she writes in and she says, I've had some hair loss, particularly in the eyebrows. I've seen a dermatologist. They've checked me for a number of different diseases. What do I have? Well, I'd love to say that you know, Karnak can give you an answer over the TV. This is one that requires a workup. We start out with some basics, and you know, what things can cause hair loss? Well, simple dermatitis can cause hair loss. Allergy to products you use can cause hair loss. Hypothyroid conditions, you've checked that can cause it. Poisons can cause it. There are autoimmune diseases like alopecia areata. So really what we need to do is sit down and in a systematic fashion identify, first of all, what is the pattern? Where is it at? Is it somewhere else? Is there something else going on? And if there is, where do you go? And then what's the appropriate treatment? And sometimes we don't have a good answer. Unfortunately, there are certain people that as we get older, you just lose the lateral part of the eyebrows, and that's not a disease. It's called aging. So we'd really have to examine you to know.
Do you know on biopsy about, does that help us at all?
In some cases we do. What I like to not do is to do biopsies that are going to be scarring, and so we'll try and find spots where we can kind of hide it so it won't show, and we'll take a tiny biopsy. But sometimes you have to have that to get an answer.
All right, very good. Thank you very much, and thank you for joining us on our website. We appreciate all of your questions, and we appreciate the opportunity to answer them. Be sure to join us next week on South Dakota Public Broadcasting at our regular time and call in or email your questions. Then watch for our columns in your local newspaper. Listen to our On-Call Conversations radio show on the station near you. And until next time, stay healthy, people.